Great. Thank you so much, Vincent. I am thrilled to be here today to speak about eating issues and specifically food selectivity in those on the autism spectrum. I am at the Children's Hospital of Philadelphia and the Perelman School of Medicine at the University of Pennsylvania. There we go. I have no conflicts of interest to share. I have had some grant funding that has supported my work. So today I'd like to speak about food selectivity or picky eating in autism spectrum disorder. And I want to sort of preface this to say there are many eating issues that can arise for children on spectrum for a host of reasons. And some are more medically complicated and some have more behavioral components and some are mixed. And today I'll be focusing on food selectivity. I'm a psychologist, and so I come at this from that perspective, not as much from a medical perspective, and I'm not a dietitian. So the focus today is on a narrow range of diet and food selectivity and how we might think about helping children on the autism spectrum learn to eat new or novel foods, or non-preferred foods, I should say, as well. So when we talk about food selectivity in autism spectrum disorder, depending on how you measure food selectivity or eating issues or feeding issues, anywhere from half to the majority of parents of a child on the autism spectrum report their child to have issues with eating and with selectivity. I'm specifically talking about having a limited number of preferred foods, refusing foods based on a variety of things. It might be texture, not liking things that have a thick texture, or a smooth texture, maybe refusing things based on color, only wanting to eat bland sort of yellow foods. People joke about the yellow, bland, sort of beige diet. Kids can refuse based on food group, often excluding all vegetables or fruits. And one thing that I think we see more in autism spectrum disorder than in children in general who might be selective about food is having brand specificity and really being able to notice the difference between a particular brand of chicken nugget or frozen pizza or cereal. And if you try to replace that Cheerios brand with the ShopRite or Wegmans brand version of Cheerios, the child will notice and then refuse to eat that different food. We also see a lot of idiosyncratic requests and rules in children on the spectrum who are food selective. Having a lot of routines and requests around how foods are prepared. They need to be cooked in separate pots. They can't touch on the plate. I need to have the blue cup and the red fork. And foods can't be eaten if those rules aren't followed. All of this leads to a lot of mealtime difficulties, a lot of conflict between parent and child within the family, and parents are often making many, many accommodations to get their child to eat at all or eat a diet that they view as flexible enough for their nutrition and their health and the family's sort of functioning. So we hear parents making separate meals for a child, not being able to go out to eat, and then as children get older, seeing more restrictions in their social world as they begin to maybe have persistent food selectivity that in other children has sort of gone by the wayside. So what we see uniquely, it seems, in autism is that this food selectivity is pervasive and persistent. So in typical development, if anyone spends time with any sort of 2 to 5-year-old, they're often very picky about what they eat. My daughter had a period of time where if there was any speck of something that looked green on any food, like any little seasoning or herb that sort of snuck on there, she would say it was salad and refuse to eat it. And that's a pretty typical sort of presentation. We see selectivity and preference. But what we see in autism is that it lasts longer into school age years, into adolescence, and there's more and more research that we're seeing this issue persist into adulthood, and that it might be more intense in many cases. And all of this certainly leads to health risks. If you have narrowed your diet to the point of often very high density, high fat foods, or you have no distribution across food groups, you're likely to see some nutritional deficiencies. Not all the time. Sometimes we see that kids can sort of get what they need nutritionally in the small select range of foods they'll eat, but they're certainly at high risk for those deficiencies. And when you do a more careful sort of nutritional panel, you can often find them. And then there's certainly a risk of being underweight if you are not eating the sort of appropriate quantity of food, or you're really narrowing what you'll eat. But we also see an increased risk of obesity. If we think about a child who has a narrow range of foods they like to eat, but their appetite is appropriate, and what they typically eat are those high dense, high sugar, high fat foods, lots of crunchy, salty things, lots of pizza, the sort of kid diet of chicken fingers, macaroni and cheese, etc., you're going to be more likely to have an increase in weight and some concern related to obesity. So when we think about treatment, and this is what I'd like to focus a bit more on today, let me orient you to this sort of graph. Across the bottom, we've got developmental age. And so I'm focusing on developmental age because we want to always match a treatment to the place the child is at developmentally. And so if you are a 3-year-old functioning as a 3-year-old, you would think about one developmental presentation. If you are a 6-year-old whose cognitive and language abilities are more aligned with a 3-year-old, we might still think about that 3-year-old presentation when we think about treatment. So along the x-axis, we're thinking about what should a child get in treatment depending on their developmental age or sort of how they're functioning. And then up that y-axis, we're thinking about severity. How severe are these feeding and eating issues and related to food selectivity? So what we know that the field does very well and that there's a pretty good evidence base for is an intensive behavioral treatment program. And that's often in a day treatment or an inpatient program. They're often called feeding programs in your local hospitals, And they're really effective for younger children with perhaps more limited cognitive or language abilities, and for those who are in a sort of medically acute position where they really need to be eating, they need to be eating more and a better variety, and they need to be doing it quickly because their health is significantly at risk. Maybe they're at risk of having to be tube fed, they're significantly underweight. Those are folks for whom this intensive behavioral treatment, it can be a very good fit. And we know that it works, and there's something available. But what's tricky is that if you think about a child, and if we're thinking about those younger sort of ages, being in a day treatment program where you're at the hospital for treatment from 8 to 5 for 3 meals a day, or in an inpatient program, it's okay if you miss preschool or you're missing some of your programming, or that happens at the hospital perhaps in the middle of your treatment day. But when you get a little bit older, and maybe you're doing pretty well in school, you're in that academic environment, things are sort of stable, taking, these programs might be like 4 weeks at a time for 3 meals a day. Taking 4 weeks out of your day can be pretty tricky to fit in and sort of maintain school. And so again, if you also think, we're thinking older and we're thinking in that lower severity range, if you're not at as much medical risk, you might want to think about something in an outpatient environment that allows you to maintain the rest of your day and sort of your functioning while also getting treatment. And so what we've seen emerge are some parent training programs that can be conducted in an outpatient environment. And these have taken 2 forms in particular. One is taking what we know works in those intense behavioral treatment programs designed for feeding issues, and then converting that into sort of a parent training model that can happen in an outpatient basis. And we've seen that there's a program called Autism Meal Plan that comes out of the Marcus Center for Autism at Emory University. Emory School of Medicine, and they have taken this sort of outpatient model that's based on an intensive behavioral treatment program. What we've also seen is that there are some evidence-based programs for parent training in general in autism for challenging or disruptive behaviors, and people, Cindy Johnson, Tris Smith, Larry Scahill, and others have taken those programs and modified them to treat feeding issues or eating issues and do that in an outpatient environment. So people have sort of taken 2 different directions to try and treat this population who maybe has less severe eating issues, but is still developmentally younger, chronologically younger. But this leaves us with a whole host of individuals on spectrum who really probably aren't a good fit. The current treatments are not a good fit for supporting their food selectivity or their eating issues. So I was particularly interested as a psychologist working in an outpatient center seeing children on spectrum for treatment, to think about what we could do to help the sort of later school age, pre-adolescent children, youth, who have a lower severity of their food selectivity. So these are the families who I would see in practice who would comment on how their child had been picky forever. Maybe they had tried a feeding kind of intensive behavioral program when they were younger, or not, because it was sort of that the child was healthy enough, not nutritionally compromised, and able to sort of make it through. And there were other concerns that they had that took higher priority for treatment. And now that they're getting into these later years where things maybe have stabilized a little bit, they're thinking about how they might be able to treat this food selectivity. And what I found was that there was really nothing available in the literature, nothing that had a solid evidence base, or that I, as a therapist seeing children and families, could pick up and use from a treatment manual. So I started thinking about what would that treatment look like? How would it be developmentally appropriate for this group? And so first of all, as children move into the school age adolescent years, they're developing more abstract cognitive skills. And so thinking about those intensive behavioral programs where you're doing a lot of rewarding eating, you might be manipulating appetite, but you're trying to sort of get the child to be on your schedule with eating of, here, I'm going to give you something to eat and I'm going to reward you for that. And we're going to try and quote unquote, extinguish other behaviors that get in the way, and shape your behavior to more align with a broader diet variety. But as kids get older, that's not always quite enough. And we need to attend to their, particularly their autonomy and their self-determination. They are able to think more abstractly about something as they get a little bit older, and they're able to leverage those cognitive skills to be more independent and to have more of a say in their treatment plan. And that's really important, I think, in those pre-adolescent years. And the hope is that if we could combine these two things, we could develop a treatment program that would also provide more sustainable gains over time and a skill set that could be applied in any situation. One of the things about the intensive behavioral treatment programs is that they often develop sort of a structured mealtime, which can work really effectively for getting kids to eat. You sort of set up what happens, you're providing food. It's a little less of a natural mealtime environment. And so that's harder to apply for someone who's heading into adolescence, who's going to be maybe not only eating at home, they might be eating if they've made a friend at a friend's house or at school or in more group settings. And so we want them to have skills that they could apply anywhere they might end up facing a new food. So it led me to think about a cognitive behavioral perspective, cognitive behavior therapy, which is a very commonly used treatment for things like anxiety and depression. And the idea is that you're attending to thoughts, behaviors, and actions and looking at how those all connect to one another, and how your thoughts may sort of be maladaptive or not so helpful when they interpret what's happening in the environment around you, and how you might shift those thoughts to be more adaptive and be able to do something more effectively. So if you think about being afraid of snakes, you might get to the point where you have such a fear of snakes that even seeing a picture of a snake in a book will make your heart race. And your thoughts start going of, oh my gosh, that snake could come out of the book. It could bite me. What's going to happen? I can't look at the snake, and sort of working up that anxiety cycle. And so cognitive behavior therapy would help you reinterpret what's happening to say, oh, that snake is in that book. It can't get me. I'm going to slow my heart rate down. I don't need to be as nervous. That's not a real snake. It can't do anything to me. And reinterpreting what's happening to sort of more adaptively function in light of that. There are a number of, I lost a slide somewhere. Sorry about that. Maybe it's later on. There is an emerging literature looking at cognitive behavior therapy for children on the autism spectrum. Now, when you're doing something like cognitive behavior therapy, you do need a bit of a more advanced ability to process language and use language. And so I highlight that because a cognitive behavior therapy may not be appropriate for all children on the autism spectrum. But what you're seeing on this slide as I'm highlighting is that there are pockets of treatments that are more applicable for different types of groups, and we need to be thinking about personalizing care. So this is actually children who might be able to have more of these, use more of these cognitive strategies, are a little bit underserved in the feeding and eating treatment world right now because of the intense behavioral focus of many of the other treatments. But what I highlight is that sometimes at this point in the field, we talk about sort of, are you doing a cognitive behavior therapy that's a big C, little b, really emphasizing the cognitive piece and having less focus on the B piece, or vice versa? Are you using some cognitive strategies, but you're still making it a pretty behavioral intervention? So I saw this in our pilot study that I'll talk about for the treatment we developed. Some of the children who maybe had a bit more limited language, now still had speech. We think about this treatment maybe being, that I'll talk about, being appropriate for a child whose verbal ability, verbal skills are around 7 or 8 years old. But even if children were sort of on the lower end of that, they could use the cognitive strategies in a more routinized way that sort of had a behavioral feel to it, even though they were using those cognitive strategies. So I emphasize this, that practitioners and you as their parents on the line, thinking about what's the most appropriate treatment and how do you communicate with a provider to say, these are the types of things I think might be effective for my child. Can you make modifications? And the field is knowing more and more how to do that. So we built from this idea of developing a sort of cognitive behavioral treatment for food selectivity, and developed something called the buffet program, building up food flexibility and exposure treatment. And we used a participatory research model. So we had a stakeholder advisory board of psychologists, occupational therapists, parents, adults on spectrum, nutritionists and dietitians, and a social worker to help us think about, what does this treatment need to look like? We sort of had a general outline, and they helped us think through each part. We had 3 focus group meetings as we were developing the intervention, one once we had a functioning treatment manual, and then after we run our pilot trial. And so what emerged was a 14-week outpatient treatment that we're calling a multifamily cognitive behavioral treatment. So we had parents, children, and therapists attend all 14 sessions, 90 minutes per session. And this is what the treatment model looked like. And we have published the initial paper describing the intervention in the Clinical Child and Family Psychology Review Journal. But what I'll bring your attention to start in this figure is looking sort of from the bottom up. Our end goal with treatment for this group is certainly to have a larger food repertoire. We want kids to eat more foods and a wider variety of foods. But what we also want, and what I hear from parents almost more sometimes, is that they want food to not be such a big deal for their child. They want them to just be more flexible so that they can sit at the table with someone else eating a food they don't like, or they can go out to dinner, or they could maybe prepare 2 things in the same pot, even if they're divided once they get on their plate. And so we talk about all of those sort of aspects of food as food flexibility. And I think we are interested to think about whether these are 2 separate outcomes or one leads to the other. Maybe once you're more flexible about food, then you can expand your repertoire. But I think they're separate, and I hear them separately from families. And that was really important as we developed the intervention. And so as you move up the figure, the idea is that regardless of why you don't eat a food, it might be that you don't like the sensory experience of that food. It might be that you had a bad experience with it once, so you sort of have an aversion. It might be that you're brand selective, and so you like one type of that food and not another. Regardless of why you've gotten to that point, generally when faced with a new, novel, or non-preferred food, children become anxious or stressed, and they're pretty rigid and inflexible at the prospect of eating a new food. So the idea was, let's design a treatment that focuses specifically on improving anxiety, decreasing anxiety, improving flexibility in a way to build skills for facing a new food. And that if we had that foundation of skills, we would be able to apply it to lots of different foods in support of expanding food repertoire and improving food flexibility. So we designed sort of 4 child treatment modules, you might say. I've lost a slide here. And so those first two pieces are anxiety and flexibility. We try to develop coping strategies for anxiety, learn about that anxiety cycle, what happens when you see something that makes you nervous or stressed, what does your body do, what thoughts do you have, and how do your actions fall out from those things. We also help kids think about flexibility. What does it mean to be flexible? We start from thinking about sort of physical flexibility, how can your body be rigid or flexible? And then we move to how can your mind be flexible? And for both anxiety and flexibility, we're building from evidence-based interventions that are available for children on spectrum. Anxiety and are designed in this group model that we think is important for this treatment, which I'll talk about in a moment. So we built from the Facing Your Fears intervention, that is a group treatment for anxiety for youth on spectrum, and the Unstuck and On Target treatment program, which is designed to improve flexibility in autism. And so what we did was took, to some extent, aspects of each of those treatments directly, but also modified them to be appropriate for food. And then we paired them with things related to sensory exposure and taste exposure and taste knowledge that are part of those feeding programs we talked about before, the behavioral interventions. So lots of exposure to new foods and increasing sort of knowledge about how to describe foods. We'll also talk about that in a minute. All of what underlied this was strategies we know are effective for children on spectrum in treatments, things like building in rewards, visual support, scripts, routines, and then also the social facilitation idea. For any child, there's some literature, not just children on spectrum, that children are more likely to eat something new or novel when other people around them are doing it, particularly children. So we wanted to see how that worked for children on spectrum. And it depends sort of what the mechanism is. If a child is more likely to eat a new food when their peer at school eats it because they like that peer and they want to be like that peer, that may or may not be something that's motivating for a child on spectrum. But if they're more willing to try a new food because that other peer ate the food and didn't throw up, didn't gag, didn't make a disgusted face, and that as a result, they're more willing to try it. It was sort of an exposure. That's a social facilitation that we might feel more confident would be effective for children on spectrum. We pair all of these child-focused treatment components with parent training components. We do some psychoeducation. We expose the parents to everything the children are learning to support generalization. But we also really focus on what it's like to be a parent of a child who is food selective and has been probably for a very long time. So how do you help expose your child to new foods in a way that helps them move forward while also protecting them and supporting them through something that's pretty difficult? And if this is something you've been dealing with for, since they were 2 and they're now 10, 11, 12, how do you approach that as a family where you, in the past, were making a lot of accommodations and sort of being willing to make a separate meal or not go out to a restaurant, and all of a sudden you're changing the game? How do you address that as a family? We also build in some modeling and role play, again, to support the generalization piece. Just to highlight that reward kind of component that I talked about, we have something called buffet bucks punch cards. You get a punch on your card, and when you get your 12 punches, you can trade it in for something preferred that you identify with your family. That is something the child is interested in earning. What I want to highlight about this is that we don't give punches and buffet bucks for eating a food or taking a bite of food. We give buffet bucks for demonstrating the skill of being flexible or the skill of being brave. And it's hard to know. Kids may still think they're getting rewarded for eating the food and taking the bite of food, but the language we use is around how you were really flexible in eating that peanut butter and jelly sandwich that had more jelly on it than you'd like. Or you were really brave trying that pizza from Domino's instead of Pizza Hut. So the treatment is designed in 14 weeks. Across the 14 weeks, we do group-based exposure, sensory exposure, and taste activities all together, parents, children, therapists. And we provide those reinforcement and rewards throughout. The first half of the intervention is more didactic, focused on building those skills related to anxiety and flexibility, introducing parents to some of those concepts we were talking about. And then the second half of the treatment, parents and children in their sort of duos, their dyads, work together, specifically exposing the child to foods that they care about as a family. The crux of where this intervention, I think, is different than some of the others that are available is around this cognitive restructuring and the idea that you have a maladaptive thought or a food faux thought that keeps you from eating a food. It sort of sets up the problem with the food. And then you have a food friend thought that can restructure that thought to be more adaptive and allow you to help to sort of eat that food, consider eating it. So for example, the food faux thought might be those chicken fingers look gross. Well, if something's gross, you're probably not going to want to eat it. But you can restructure that thought to looking gross doesn't mean they taste gross. So just the fact that it looks gross doesn't tell me anything about how it's going to taste. So I might as well give it a try. And this cognitive piece is really core to what we're trying to help children do when they then face new foods. So this is a very full slide, but let me walk you through it. This is how we sort of build from in that second half of the treatment, helping expose children to a new food. We help them think about what is the goal of the new food that they want to eat. So in this case, it might be eat a chicken nugget. How stressed does the idea make you at this point? And why do you care about that goal? We talked about autonomy and self-determination. We really want kids to want to eat that new food. And if we can find the hook and the reason why they care about that new food, we're much more likely to get their buy-in and their motivation to work on this hard thing. So in this case, it might be, I want to have something to eat in the school cafeteria. We hear adolescents, as they're more and more away from home in different environments, they may be motivated to be able to be flexible in those environments and not either stand out, not go hungry, and be comfortable in facing those foods. What's the reward they're working for, and we know this is hard work, and so we are going to reward the hard work. We have them build a 6-step hierarchy toward eating that new food. And here's a very straightforward example that might be similar to other programs you've seen that are out there to support food selectivity and picky eating. First touching the food, taking a little taste, eating a small bite, eating a full bite, eating half of a nugget, eating a whole nugget. Now, our 6-step hierarchy can take any shape or form depending on where the child is at with the food, what the problem is with the food, what their sort of food faux thoughts are about the food. It might be that even having the food on the table is going to be step number 1. It might be that they have eaten one whole nugget, but that's about all they can manage, and so they're going to have a hierarchy that starts with eating 1 nugget, and then it moves up to 2, and then it moves up to 3. Maybe the issue with the chicken nugget is the sensory experience of touching the breading, and so you would build a hierarchy around that. It's a very flexible model for whatever is needed for that child. Again, it's a structure and sort of a outline for how to build skills around eating new foods. And the idea is not necessarily that you finish those 6 steps and are able to eat that food and integrate it into your diet. It's that you've taken a first step toward eating it, and then you'll figure out what happens next. You may need to build another hierarchy to move on to the next step with the food. You set up your coping strategies ahead of time. What are those food faux thoughts? What are the food friend thoughts? You have your body and mind calming strategies for the anxiety prepared. You have your food flexibility script ready. This is sort of their working planner for when you then go do that food exposure. And this is the very targeted exposure that parents and children are doing together. I also talked about that sort of global big picture exposure if I go back here, at the top part there, the exposure, sensory, and taste activities that happen in large group format, everyone together, are happening throughout the entire intervention. And we do that by having a snack time where foods are presented, something that's sort of novel and maybe a little bit, non-preferred or less likely to see children eat, and then something that we expect that they might be comfortable eating. So something like we might have a cheese week, for example, and so there might be crackers, pretty plain cheddar or American cheese, and then like a cheese spread. And that cheese spread, no matter how delicious I think it is, usually they think it's pretty gross. So the idea in that snack time is that everybody's presented with the same food. But the first rule of snack time is that they don't actually have to eat the food. And so we're initially trying to give them exposure to new foods. They do have to keep it on their plate. And we rotate each week who is going to be the snack time helper. And they have to hand out every plate to every person in that room. So they may have to pick up 14 plates that have that really gross cheese spread to them and hand that over to someone. So now, if they're willing to try the novel non-preferred food, they can get a buffet buck punch, and we do that sort of in that group setting to build that social facilitation. But they don't have to. So there's this contrast of the sort of exposure that happens at the group level where we're building exposure, giving them lots of time with new foods, but it's a little less targeted and personalized. But what we are doing in that group setting is this food dictionary activity where we're helping kids build a vocabulary around food. What does it look like? What does it smell like? What's the flavor? What's the texture? What category is it? How can they learn to describe things about food that also allows them to generalize information about food? What do they like? What do they not like? What we saw with one of our groups in the pilot study was that it turned out one child actually really liked spicy food, but he never knew how to describe it. And for the most part, people hadn't been presenting him with spicy food. But when he was trying some foods and could label it as spicy, he was then able to connect that actually those are the kinds of foods he likes. We have them think about how would you eat this food and how could you modify the food depending on what it's like. So in this example with carrots, you could use your hands, you could cook them or dip them, you could make them into a smoothie or juice, put them in a salad. There are lots of ways to prepare that food, things you can do that change the texture. So if you you prefer crunchy foods over soft foods, you might be able to negotiate and work with your parent to advocate for having carrots, which allows you to have that vegetable that does good things for your body, but in crunchy form, not soft form. And so how can kids advocate and have autonomy around what they're eating? We get lots of practice. Once we've introduced the idea of food foe and food friend thoughts, they get practice building those thoughts around in this sort of group environment. And then at the end, they make a food review. So, 0 or 1 fork is they really dislike the food. 5 forks, they really like it. And again, helps them learn to generalize. So we ran a small pilot study to develop the intervention, see if it was acceptable to families and if they were satisfied with the treatment. And we published that data a few years ago. And what we saw was that we had a very high attendance rate, and we had no attrition. No one dropped out of the intervention, which was pretty amazing, and I think spoke to the commitment of the families involved in this treatment. So we perceived it as acceptable to families. And then we looked at satisfaction in a number of different ways. We looked at understanding of material, the amount of material, the helpfulness of the sessions, and the enjoyment of the sessions. So just to orient you to this slide, there's a lot on there. We've got sort of each of those 4 sections and then parents' ratings of endorsing those statements. So when we looked at sort of understanding of material, we saw that over 90% of both parents and children said that they understood what was talked about in the session. In terms of the amount of material in each session, in general, they thought there was the right amount of material. Children sometimes thought there was too much material, and that was really helpful for us, and we can modify the treatment manual to scale back a little on some sessions that seem to have too much content. And I should say children and parents made these ratings after each session, so we could evaluate each session of the treatment separately. We asked about how much they thought the session would help with the food selectivity, and we saw generally a range between totally helpful, a lot helpful, and a little helpful. And again, tried to attend to when were they saying this was only a little helpful and how could we adjust. And in general, families said they either totally enjoyed the sessions or enjoyed them a lot. There was sort of this one pocket of some sessions that were viewed as not as enjoyable to kids in particular, and so we're attending to that to see how we can shift that. So as we head toward, thinking about opening it up for questions, what I can summarize is to say that food selectivity is pervasive and persistent in autism spectrum disorder. There's a high risk for obesity and other health issues that we really need to attend to, as well as, honestly, what I would often hear from families is just the stress of day-to-day life. Kids have to eat multiple times a day, and so if you're facing conflict and meltdown, every time you present a new food or encounter or any food, it's pretty stressful for a family. What we see is that treatment is quite limited for older cohorts or children and youth who have sort of abilities in that school age and above range, and that buffet might be a promising new intervention to support individuals on spectrum in that range. But what this also leads is we think back to that graph I had, that figure of what available treatments there are and what treatments are sort of absent. We need to be developing new treatments, and we need to be thinking from a precision healthcare perspective and sort of personalizing healthcare. So you might have 4 different youth who have food selectivity, and previously we really just had one treatment available, or 2 different kinds of treatments, behavioral treatments versus sensory treatments. And I'm simplifying this, of course, but what we need to think about is having more treatments available and thinking about each child and which treatment is appropriate for which child. You really want to think about the right intervention that targets the right treatment target. What do you care about a child improving upon following treatment? Do you need them to be eating a wider variety of foods? Do they need to eat more foods? Do they need to eat more nutritious foods? And you will choose your intervention accordingly. As you probably saw, or as was sort of infused, buffet is not a nutritionally focused intervention. We can have kids work on eating new foods that have no nutritional value because they're building the skill of eating new foods, and that's where we believe we need to start. We want to think about the right time for treatment. Are they medically at risk? And so we need to get in, obviously earlier is always better, but children on spectrum have a lot of challenges to attend to at different points across time, and families make the best decision for what to attend to at a different point in time. And so is it something that there wasn't as much medical acuity and risk, and so it was able to be put off for a little while, and so as they've gotten older, you can now sort of attend to it. Or maybe it's the thing that's causing the most problem at home. And so when they're 2, you are going to get into that right from the get-go and try and work on your intervention. But thinking about developmentally where they're at and what the right treatment is for their developmental stage. And then what's the right context? Do you want to be doing this in a group? Do you want to be doing this individually? Should the parent be the focus in a parent training model to support the child at home? Or should the child be attending the intervention, or the youth, the teenager? Can you do this in an outpatient environment? Do they need to be in an inpatient day treatment program? All of these components should go into identifying the right intervention at the right time in the right context for a child. I appreciate you taking the time today and sort of hearing this snippet and brief overview of my work on food selectivity and how we think about treatment for a currently underserved group of youth on spectrum. Thank you.
Thank you so much, Emily. Okay, so we are going to open it up for questions now. We received a few so far. Please continue to send them in. So I'm just going to dive right in. Emily, the first one was about your pilot study. If you could just provide more information about the sample.
Sure.
So like what did the population look like that you studied?
Yeah. I apologize for not including that. I think this was a little bit big picture. The children in the pilot study were 8 to 12 years old. They needed to have verbal abilities at a verbal mental age, or sort of a verbal level of functioning older than 7 years old.
Okay.
And we conducted the intervention in an outpatient environment, not a hospital-based environment at all.
Okay. And we're getting more in here, so I'm going to just try to like combine some if I can. Let's see here. Okay, so a number of people are asking about, how could they do a program similar to this? So have you expanded your program or made it available for anyone else to use? Or, I mean, could people even take your published results and work with someone?
Yeah, that's a great question. So my goal is definitely to have a treatment manual that is available for families and clinicians to work with. And we know there's a lot of research that it takes way too long for interventions developed in the lab to be available and used readily in the community. So I certainly have the goal of making a treatment manual available, but I also want to be sure that there's an evidence base to support the treatment before I put it out there in that manner. So there's not yet a treatment manual available. I'm currently working on, grant funding to support the next study so we can say that and have it be available and something that perhaps insurance would reimburse. But what I think, as you just said, the article that I mentioned where we published these results, all of the figures from this presentation are in that manuscript and in that paper. And so you can pull that, and if you did have a provider who knows how to work with children on spectrum, knows cognitive behavioral strategies, or works with eating issues or feeding issues, I think that they could take that that paper and try and work from it to help you. But the goal is certainly to make it available as soon as we can.
Okay, great. And then some people were asking about strategies for teens or adults. Can you touch on that? I mean, would this kind of thing be applicable?
Absolutely. I think there's a really clear sort of upward extension we could do to modify this for teenagers and for adults. There is a little bit of literature in adults who just have picky eating, who are not necessarily on the autism spectrum, where cognitive behavioral treatment can be effective. So I think that some of what we do in the intervention just has sort of cute graphics and things that are maybe developmentally focused on that younger age range. And so with some modifications, I think it's absolutely appropriate for older age ranges.
Okay, and related to that, would you say it's ever too late, or when could you just dive in at any point using your approach?
I would say it's never too late. I think that, when you have any behavior that's any sort of thing in your life that is long lasting, it's always hard to make changes, but always worth trying. And often as individuals get older, and I think this is what we saw in the pilot study, there's a developmental shift to you're not a young child anymore where it's okay to only eat chicken nuggets and pizza. People around you have started to expand their diet. And you may seem a little more out of the norm eating different things. And what we hear often is that kids want to, be more sort of integrated in that way, and the motivation is different. Or they know that their health is at risk and they would like to do something to improve their health, to feel stronger, feel less tired, have more energy, and thinking about what they as you head into adulthood can really make a difference.
And then we had some questions about individuals who need more support or maybe nonverbal. Do you have any recommendations?
That's a great question. I think that it probably depends on the child whether elements of this intervention would be effective. In general, I think children who need more support verbally or cognitively might be well served by the interventions that are available and designed sometimes for younger children, while integrating the idea that even if level of functioning might be a little bit lower or needing more support, they're chronologically at an age where we want to give them as much autonomy as possible and choice in what they're doing. I certainly think if someone can cognitively, for example, use an AAC device to communicate with those verbal cognitive strategies, there's no reason you can't modify to fit that population.
And what would you say is a good place to start? So if parents haven't really delved into this to use sort of an evidence-based approach for selective or picky eating, what would you say is kind of like a good overarching place to go, or something that would be like a good go-to for families who are just kind of beginning this?
Great question. So I would think about any time you're trying to have your child do something that they haven't done before, whether it's something that makes them stressed or nervous or anxious, you want to just start with manageable exposures. And if you can do it at sort of a family integrated level, that's a great way to start. So, if you have more than one child or you just have one, thinking about, maybe you have Wacky Wednesday where you put something new on everybody's plate and no one has to eat it, but it's there. And you keep trying those new sort of subtle exposures that build into larger things. We know there's research that children need anywhere from 12, anyone actually needs anywhere from 12 to 15 exposures to a new food to make a decision about whether they like that food and would integrate it into their diet. So if you think about at a very basic level with a baby, when you're exposing them to new foods, if you give them something and they chuck it on the floor, they don't like those peas and they chuck it all over, parents tend to be less likely to reintroduce that. They say, oh, they don't like it, I'm not doing it again. But the child actually needs many more exposures to adjust to it and make a decision about it. Now, it's possible children on spectrum need even more exposures than another child, but we just want the routine of novelty, and you can make that predictable. And so if you sort of set up that Wacky Wednesday thing or Tricky Tuesday with a new food Tuesday night at dinner, you can be setting up those exposures where every time they're exposed to something new, in theory, they're decreasing their anxiety to that new thing and maybe, or just learning how to tolerate it being there. So finding ways to integrate it into your life, I think, is a nice place to start.
Excellent. You kind of touched on this, but I guess what would you say, is there a place or a time or like how would you kind of intervene before? Like, is there any prevention strategies?
Oh, that's a really good question. I think, the literature would say that all of these things we're talking about with sort of initial exposure to new foods with young children are really key. So having food be fun, having food not be a stressful dynamic between parent and child, and making sure that you're continuing to present foods to improve that exposure can be really helpful. Food, this is a hard dynamic, and I think when you think about having young children, what are the two things people ask when you have a baby? How are they sleeping and how are they eating? And it's such a focus, and it's such a burden might be a strong word, but it's such an important part, I think, for parents and their identity of, are they feeding their child effectively? And if you become stressed about how well you're feeding your child or how well your child is eating, it's really hard to then sort of stay calm and approach that from a systematic sort of exposure-based perspective. So even maybe jotting down for yourself what food you've introduced and how many nights in a row did you introduce them might be a way to keep yourself sort of focused on continuing to expose your child to things, even if it didn't go well that first time.
Okay. We've had a few people talking about their child may be less picky in other environments. So how do you kind of, do you have any suggestions for, if a kid eats more foods at school than at home, how can you kind of maintain a sort of openness regardless of location or environment?
Right. That's a really great point. And I think that does happen. So again, I would say just even, with my own daughter, I know she's more likely to eat things that are new or a little less preferred when she's at school and really hungry at lunch. And so keep sending those foods to school, keep that exposure going so that they're building, that variety in that other environment. And you can think about ways to generalize from home and try and build those in at home rather than just school, or if they're eating something at their grandparents or with their, cousin that they won't eat at home, have that happen with their cousin, or then bring their cousin to the house. And so you're trying to generalize that to the new environment. And I think the other, I'm not sure how much it came through, but the other really important thing to remember in all of this is that children are allowed to have preferences about food. We all do. And so it's not necessarily that every child needs to eat every food. It's okay for them to dislike foods, but we want to encourage them to advocate and be able to negotiate. If a parent says, we need to have a vegetable at dinner tonight, which vegetable would you like to have? That the child can negotiate that and be willing to identify something that works. And it doesn't necessarily, they don't have to only eat the thing the parent wants to eat, though we want them to be flexible enough, even if it's not their favorite food, to tolerate it.
Okay, so someone had a question about if any of the subjects in your study experienced any anxiety and how you dealt with that.
Yes, I think so. It's interesting. When we were designing the treatment manual, we actually tried to stay away initially from using the word anxiety and tried to focus on stress because we thought anxiety might put kids on edge or they wouldn't want to call it anxiety or fear. And when we were talking about stress, I had one kid look at me and say, "Don't you just mean anxiety and worry?" And I said, "Yes." So part of what we're doing is we're building a coping toolbox for what to do when you face that new food so that you're not just faced with it and sort of panicking or getting very anxious. You have practiced deep breathing. You have things that can help distract you. You have ways to calm down. You have those cognitive strategies that help you adjust what you're thinking and adjust what your body's doing so that they can then face that new food. And I should say, as I'm talking about these ways you can integrate this into your family's life on a day-to-day basis, you want to make sure your child's prepared for it. So you don't want to just spring it on them. You want to talk about that you're predicting that we're going to do something different. And so what would they do if there was a food on their plate that they didn't like? Well, they could always take a deep breath. They could always, turn their plate so the food was a little further away from them. You're building their coping toolbox to face the new food.
Okay. Let's see. Someone was asking, this is a pretty broad question, but what's been most surprising in your research over the years in this world?
That's a great question. One of the things, and I didn't talk as much about sort of the causes. I think there are a lot of reasons children on spectrum might be selective. And we think about things like oral motor function or swallowing ability affecting what you eat. But fine motor challenges, like, being able to use your hands effectively. So things like handwriting is often a challenge for kids on spectrum, and they might get occupational therapy to improve that. But that also impacts how you use silverware. And I think I was really struck by school age or sort of pre-adolescent youth on spectrum they were making choices about food based on not having to use silverware. And that was really striking to me, how much that other sort of area of weakness was impacting what they were doing. And so that's something you might, as we talked about that buffet building planner, you might build a hierarchy around. How can you practice transitioning from, a food you might have eaten with your hands to using silverware? And you might build 6 steps to get practice with that and more comfort with that.
Okay. So people were asking about school and, if you have any experience in putting items into an IEP related to food, or if there are any resources that parents could send to teachers or principals.
Yeah, that's a great option. And there are actually a few programs. There's one coming there was a study published in the UK. I think the author's name is maybe James Galpin, where it's a school for children on spectrum, and they built a sensory snack time into the day. So snacks are available in that environment, and they built in exposure to new foods into the program. So I think that's an ideal way to do this. So certainly if you have a school that's on board, a classroom that's on board in that way, you can encourage them to do this at a group level because that's effective. And my guess is kids not just on spectrum would benefit from having exposure to new foods. Building it into your IEP can be great. The challenge is the IEP, they always want to know whether it's impacting their access to, educational curriculum. And sometimes that can be tricky, but sometimes that you can find a way to integrate it. If your child has a lunch bunch kind of, social skills activity, that can be a great place to integrate food if you have a game provider. So I think anywhere you can try to do that, the better. I think if you are doing things like sending a more novel or non-preferred food with your child for lunch, communicating with whoever is on duty at lunch or the teacher to say, look, I know that they might not like to eat this, but we're working on exposure to it. And so I'm asking that he eats it in his lunch and that he sees it every day. or that, can you help her be sure she takes it out onto her tray and doesn't just leave it in the bag? So there might be small ways that you can sort of get them on board rather than hearing later, your child doesn't like freezing, and you send them every day, but sort of highlighting why you're doing what you're doing, just from an increased communication perspective, might be helpful.
Okay. I think maybe this would be the last question, but what about when kids might be more adventurous, but then they sort of regress and stop eating lots of different types of food? Do you have any recommendations?
Yeah, that's a really good point. And, anytime you start, first of all, anytime you start any type of intervention like this, you want to talk to your pediatrician and make sure you're sort of medically covered and ready for making those changes. Because what we do know is that sometimes when you start to work on new foods or changing sort of eating habits, kids will regress and they might even stop eating the things that they would normally eat. And so if your child is teetering on being within an appropriate weight range, you want to be sure that they're still getting enough food to not be then in a more medically concerning place. I think making sure that your goals are appropriate and not too lofty to begin with can be really helpful. And so sometimes, I've seen adolescents have goals for themselves that are, really, really cool and really admirable, but really challenging. So, someone who maybe wants to eat sushi because they see their family do it and they want to eat something when they go out to that, rate that restaurant with their family, diving right into a raw fish sushi roll might be a little more daunting than something that doesn't have raw fish. Or maybe that sushi roll is just too much to start, and they should start with rice before they get the wrapped seaweed and the insides of the sushi roll. So trying to make sure that your initial sort of plans for exposure and things to work on are within the right sort of developmentally appropriate and within the right window of focus is really important.
Okay, and this is just the last one actually. Obviously you're in the world of psychology. Do you have any recommendations for, say, like medical resources or like dietitians that work with individuals on the spectrum? Are there any go-to places that you would recommend for parents?
So I think there are some nice resources online. The Autism Speaks website has an eating toolkit that can be a nice place to start. The manuscript I've described, and there's a nice literature emerging on the behavioral feeding programs that I described, those intensive programs that can be also a place to start for providers who are trying to understand the sort of basic components that go into helping improve a child's eating.
Okay. All right. So that is all the time that we have. Thank you so much for this presentation and for taking the time to answer all these questions.
Thank you for having me.